Our conversation continues with Dr. Edna Busire, medical anthropologist at the Aga Khan University Brain and Mind Institute. Now, tell us about brain resilience, and then you tell us what the institute has been doing.
Yeah, so
research.
Thank you. So brain resilience, what we are trying to do is to understand why some people still get exposed to so many stressors, but they are able not to get Alzheimer's. So as I mentioned, before, we all get exposed to different stressors. It could be socioeconomic stressors, it could be environmental stressors, it could be physiological related stressors like diseases. People who have, for example, chronic diseases like cancers, you can imagine it can be quite stressful.
Yep.
So the stress itself really contributes to cognitive impairment. But we have people who've been exposed to all these stressors, but they still continue growing. They are able to withstand, they are able to bounce back, and they are able to just adapt to their stressors and live normally. So what we are doing is to understand this resilience. Resilience means really being able to cope, being able to adjust, and being able to grow despite the adversity that you are exposed to. So what we are trying to do is to understand why are some people exposed to different stressors, but they're able to cope while others are not, so that we can use these learnings to be able to develop interventions that can support those who normally struggle with the stressors. So that is what we are trying to do, because at the end of the day, we want to ensure that all of us, as we grow old, we are able to maintain healthy brain.
So how are you studying that?
So how we are studying that, first of all, is to talk to communities. I'm an anthropologist, so going back to the communities, talking to them, understanding how do you cope when you have issues? What helps you to manage? What helps you to become resilient when you lose your loved one? People are unemployed outside here. How are you managing? Because we don't see people dying because they are unemployed, right? But there is a stressor, and it might affect other people badly than others. So we ask them questions. But another thing that we are doing at the Brain and Mind Institute, we are collecting biomarkers. These biomarkers are going to help us to be able to see if some people have maybe genes or something that will help them cope better than others. And we are also working closely with the oncology department being led by Professor Mansour Saleh, just to be able to talk to some of the cancer patients to see why some cancer patients maybe end up becoming more stressed than others who also have cancer. So we collect samples, we collect blood, we collect things like saliva, just to see the stressors that can really impair people's cognitive aging, but also what helps some people to really, withstand the difficult situations that they are in.
So obviously there is a mental health burden in the country at the moment. I know that when we talk about then the different dementias that are there risk factors in society today that could lead towards some of this that we are seeing then now with the numbers that you talk about? Yes,
we have risk factors. But, okay, let me talk about the risk factors, then maybe bring an alert there. So some of the risk factors include, brain injury is a risk factor. If you injure your brain, then you are likely at risk of developing Alzheimer's. Then I talked about alcohol, substance abuse, and smoking, but also obesity and diabetes, hypertension, and also education, not being able to go to school earlier. Those are some of the risk factors that we have. These risk factors are informed from broad view, from the work that has been done from the global north, developed countries. We haven't really validated these risk factors, whether they fit in our context. In our context, for example, alcohol abuse. So we have what we call the Lancet Commission that gives us some of the criteria, and even WHO gives some of the criteria or, cutoff to say, if you see this is what happens. But some of those numbers might not reflect our local context. For example, alcohol abuse. They say alcohol contributes to about 1% risk of Alzheimer's. This is from the developed world. But in our context, we know people take a lot of alcohol, and maybe the way they tolerate alcohol might not be the same without maybe someone from Europe. Our communities don't tolerate alcohol well. They get really overwhelmed by alcohol. You've seen if you give students alcohol and they sleep in class, they won't even study. But abroad, someone will drink and continue working. So we need to now validate those numbers to fit our context. When we talk about other things like hearing loss, even education, we need to contextualize that to be able to know at what time or what sort of education or what average of education really is preventive, helps to prevent someone from developing Alzheimer's disease.
How about socializing?
Socializing is very important. Thank you for bringing that on point. Socializing is very important because social isolation is a risk factor for Alzheimer's disease. So we want to understand, because in our place, in our communities, traditionally we know people socialize a lot. We live in extended families. People talk and people socialize, compared to people from the global north who live in isolation. But we tend to see nowadays, even in Kenya here, people trying also to disintegrate.
Yeah.
We see people living, the elderly people in the villages and coming to town and not going back to talk to them. So that is a risk factor for Alzheimer's, and people really need to think about that. Social engagement is a very very protective factor for Alzheimer's disease.
Yeah. Putting it into an African context, which I think is extremely important when we're looking at mental health, is that previously anything to do with mental health was not called that. It was, like as you said before, either a witchcraft or somebody's put a hex on you or whatever, whereby we see that in the global north, we're very quick to name it scientifically.
Yes.
And to treat it, medically. But are we starting to see now that we are here naming them for what they are, as opposed to putting societal or community labels on mental health? Are we more embracing that mental health is actually a medical, physiological, psychological problem, as opposed to calling it something else? Are we opening up those barriers? Because I imagine that somebody who was in a village setting or even in the city in an African context with Alzheimer's, wandering around the place when it was at an advanced stage, would most likely not be taken to hospital.
Exactly.
Right?
So I will say it's a yes or no. When you look at mental health, a lot is happening at the communities and people are getting sensitized. People are gaining knowledge about, okay, these are real issues. But when it comes to brain health, nothing much is happening. We don't even have a local word for dementia. You can imagine going to the village and telling someone Alzheimer's. What is that? People talk about kusahau. It means forgetting. Kusahau. But really, we really need to come down to our communities, because these conditions exist, and understand from the context, what sort of name do you call these people? When you see someone wandering around, how do you call them, so that we come up with intervention to destigmatize. If they end up, we've seen even adults, someone in their 70s being taken to jail because they were found wandering. The police will just arrest them. Where are they arresting them? They don't even know that this is a condition, and there are no policies or mechanisms to protect such seniors from our communities. We've seen seniors being lynched in many rural parts of Kenya, Kilifi, Kisii. Some people taking advantage of them, calling them again, quote unquote, these are witches or people practicing witchcraft, is because the community don't understand, and we have a role to create sensitization. That is what the Brain and Mind Institute is doing through the education programs, community engagement. We are engaging with different people at the community health promoters, chiefs, calling barazas, just to make sure that we ensure that people understand these conditions exist, and we work with these people so that we learn how do you call them in your local language, so that we can bring these words into science. What we are doing, we are borrowing from the global north. We've not done much locally, and that is what the Brain and Mind, it's not just the BMI, but other organizations also are trying to do currently.
When you go to the communities now in the anthropology work and you're trying to find out how do you deal with stresses, are you finding that different communities have different ways of coping?
Yes. So we have some cut across strategies of coping, like community, religion, people going to church, or some women coping through, we have social gathering called chamas and all these. But also we have individual related coping mechanisms where some people just have a positive outlook, accepting the situation as it is. That is a way of coping. But we have some things that some communities are coping better than others. If you find communities that are embracing togetherness, then they cope better compared to communities or families that tend to live in isolation, and so on and so forth. So, we have the community is not just about coping, but even how they experience stress. Sometimes it varies across communities. What might be stressful in your community might not be the same as my community. How you look at a person who has those psychiatric behaviors might be different from your the communities. It keeps on varying. And even how people talk about these stressors. Some people use signs and some non-verbal communications, touching the head, touching the stomach, the shoulder when you feel stressed, So we have to learn these things so that we come up with interventions that are context specific and that addresses the problems of these communities.
You talked about several other projects that you're doing.
Yes.
mentioned?
So one of it, I've talked about the brain resilience, and we have what we call Alzheimer's detection project. This is a project where then we are collecting biospecimen samples just to be able to understand the risk factors for African or Kenyan population for Alzheimer's. As I said, we are just using some of the risk factors that are from the global north. So Aga Khan University, through the BMI, we are trying to then now start validating our own, using our own population. So we are collecting samples, and at the Brain and Mind
When you
Institute,
say collecting samples,
yes.
What are you collecting? You're not picking people's brains, are you?
No, we are not collecting people's brains. So what we do, there are different samples that can be used to, to detect if someone is at risk of Alzheimer's. This includes saliva. It might include blood. We have another sample called the CSF, the cerebrospinal fluid, a fluid that is gotten from the spinal cord.
The ones that are very big shindano.
Yes, those ones can tell the protein, the amyloids, whether someone is at risk, has these proteins for Alzheimer's. So we have, we are trying to embrace technology at the Brain and Mind Institute in diagnosis, but also we have other like wearable devices that can detect if the brain is really behaving in an abnormal way. Smartwatches, and other things around, really trying to embrace technology to be able to detect these diseases. So other than that, we have another upcoming project where we are trying to...
Before that, how do you select your samples for this?
So it's an open, really. We've even put on social media, if you are interested, participate in our studies, just enroll. Then we can screen if you are qualified. How do we screen? We have a criteria. We say that these diseases are common amongst the aging population.
Yeah.
So you would assume we'll select 80s and 90 people who are aged 80s and above. No, because we now have people showcasing the symptoms earlier enough, so we start from 35 years. So if you are 18 years, we don't recruit you. From 35 years, then we recruit you to be part of our study. And if we are dealing with patients who've been characterized, what I mean characterized are those that a doctor, a neurologist has said you have this condition. So then we recruit them from the hospital. We just ask whoever wants to participate. They participate, we collect the sample and even study other things that we did not, we haven't studied before.
How well can folks who have been diagnosed with Alzheimer's cope in society?
So that's a difficult question because, first of all, I have to highlight that we don't have a cure for Alzheimer's. We don't have a cure, but we have medication that can help the patient cope with the symptoms they are exhibiting. Another thing, it depends with the social capital that they have at home. How well is your family supportive of you? How well, and this is not just about the family willingness, but also having financial resources. Alzheimer's or dementias in general, these are expensive diseases. You can imagine we are talking about conducting an MRI, a PET scan to tell us whether you have this condition or not. A PET scan is quite expensive in Kenya. And even, do we have them in public hospitals? Very few, mostly in private hospitals. So very few patients are able to go through that process of getting a diagnosis. But coming back to your question, the home environment really matters a lot. The social support, people being able to afford food for you, people being able to support you at home, not scolding you, not shouting at you because they don't understand what you're going through. Yeah. So just being able to know that these are the deficits, these are the issues you're going through, maybe giving you colored things to see. If you're not able to speak, maybe trying to speak, to use nonverbal communication, trying to label rooms, trying not to leave the patient alone at home, so that because there's a lot of falling, some accidents at home, fire, people leave their food cooking and they go sit or sleep and forget about it. So having this social capital, the caregivers, is very important. But another thing I want to highlight in relation to that is that then there is a lot of caregiver burden. Because you can imagine the financial burden, the psychological burden, taking care of someone. I've had caregivers who are as young as 24 years, 18 years. These children have to stop their careers. They can't go to work because they have to take care of their parents or their aunties. So there is also another issue of caregiver burden.
Another project.
So those are some of the key projects that we are currently running.
You are going into another one after the Alzheimer's one.
Okay. The last one is a project that is aimed to to help communities to come up with preventive mechanisms. We are trying to come up with physical activities, and we are planning to implement this in Nairobi and Kilifi. It's called the Africa Fingers Project. So it's a project that is really trying to understand what sort of activities do your communities embrace in terms of physical activities, and what nutrition, what foods do you have, so that we can craft preventive mechanisms that will work for those communities. The end goal is to ensure that as we age, everybody ages gracefully, but also with a healthy brain.
How long do you give yourselves in these studies?
So our studies, it depends. I mean, for the entire period?
Yeah, and when do we start now seeing reports coming out and saying, now we understand, actually, we have validated data from Kenya. These are the risk factors, for example, that would lead to Alzheimer's, dementia, and others. When do we expect to start
So
seeing?
we've started collecting samples, and first of all, we've started some of the background. Some of the things I've talked about is based from what we've done. That one is now part of the findings that I've talked about. But for the samples that we are collecting, we are going to analyze them. Maybe in the next 2 years, we'll have the findings from Kenya. Yeah.
Okay. So what are we looking at from a national outlook? Because the numbers that you've given us, I mean, are really heavy. Where we're looking at, I believe the number you gave was, 70%
Of the global.
Yes. Of the global burden.
Yes. Of Alzheimer's.
Of Alzheimer's.
Yes. And in Africa, now talking about Africa, we have estimates. It's between 2% to 20%. We've not done proper validation to test that.
Okay, so 20% of what? 20% of an entire population has folks today who have been diagnosed and are living with Alzheimer's. That's still a big number.
It is.
That's 1 in every 5.
Yes.
1 in every 5 people has Alzheimer's today.
Actually, globally, it's in every 4 seconds we have a new diagnosis.
That's a big deal.
Every 4th second.
Yes.
Yeah. That's crazy.
Okay.
So what's a national approach to dealing with something like this? Because if you, in every other 5 people that you meet, one of them will have Alzheimer's.
Yes.
Are they being treated? Have they even been diagnosed? Are they coping with interventions? Is there, for numbers as large as that, I mean, the other diseases where we have huge interventions with numbers like this are malaria, HIV, cancer. Alzheimer's should be right there.
Thank you.
In that list.
Exactly. You see why we have a lot of interventions for the examples you've just given out is because of donor funding. These are diseases that are highly donor funded by PEPFAR, HIV, TB, malaria are highly donor funded. You saw how the countries responded quite quickly when we had COVID-19 because of the impact. Whom does it impact, So there was a lot of, but when it comes to dementias, these brain disorders, we are not even talking about it. That is a gap. As a country, we are not talking about it. Have you, next week, on this weekend, we have Alzheimer's Day. Let's see what's going to happen. But people are not talking about it. How do you expect people to even reach facilities when nobody is doing anything? So there's a lot to do. I mean, we really need to bring the voices, the narratives of Alzheimer's. We really need to take it seriously because it's not me. It's not about that elderly grandmother or grandfather. All of us are at risk. So the government need to create awareness about this. That is the first thing. Awareness throughout the population. Our communities need to understand there is an issue. When you create awareness, it means that you are going to create demand. People, when they start seeing this issue, they need to go to the hospital. Are our hospitals capacitated to support these people?
I would imagine that if you have something with such a great disease burden, with such a high percentage in terms of numbers, that you would then have dedicated programs, that you would have dedicated outreach and awareness building around something like that. The same way you have a cancer center, or the same way you have, malaria center, that you would have something like this at the national level. So we're talking about public care. And also, I would imagine that something like that exists at the private care level, but that it would be that the call should be to have something at a national level that's dedicated to this because the numbers are incredibly high.
And just to cut you short, and the population, we expect the cases to triple because the adult population is now growing more. People used to die earlier, but now we have better medication for diseases like HIV. People are living longer. So you can imagine the risk is going to be more in the near future. By 2050, we'll actually have more cases. So the first thing, we need to confirm our numbers. As I said, we are using estimates. The second thing, yes, I know the government of Kenya through the Ministry of Health are coming up with policy guidelines and, to try and sort the issues of brain diseases, including Alzheimer's. But this has not come to realization. It's really urgent. It's needed like yesterday. We need policies and programs to start addressing the issues that we have around Alzheimer's. We need to ensure that we have equipment for diagnosis at the primary, at our public hospitals. We need to train healthcare providers. Just to mention that in the whole country, we have less than 25 neurologists in Kenya. Less than 25 neurologists serving a population of how many people? So you can imagine someone in Nyeri, someone in Muranga, how soon are they going to reach a neurologist? Do they even know that there exist neurologists?
I think one thing also, I think we're seeing some chagrin when it comes to the numbers that we're talking about here. And I think you had mentioned this earlier, that Alzheimer's is not a disease of the aging.
Yes.
Alone.
Yes.
Can you go over that again? Because I think it's important to take into consideration that you're not talking just about octogenarians who have Alzheimer's. You're talking about people who are younger. And how much younger?
Age is just a risk factor. But it's not, Alzheimer's is not all about aging. As we grow old, we are at risk, but because of multiplicity of many other factors, all those risks and stressors that I talked about, we have now people who are coming to the hospital in their 50s and they are diagnosed with Alzheimer's disease, compared to the narrative we used to hear that from 60, 80, that is when people will, and that also actually has contributed to people relegating their loved ones at home, because they're like, it's just everyone, when you age, you'll end up that way. That is not the case. And that is where our brain resilience project comes in, because we find some people at 100 and they don't have Alzheimer's. Yeah? So it's not about aging, but age is a risk factor.
Right.
Yeah, the debate that's going on is on that statistic, 20%, 1 in 5, has been diagnosed with Alzheimer's. People are thinking, 1 in 5? If it is more prevalent among the aging people, then surely 1 in 5 is a very high number.
So can I just clarify that?
Please do.
So I said in Africa, it shows up, it's an estimate between 2% to 20%, anywhere there.
Okay.
So we have to do research to really validate those numbers.
Okay.
And when you compare to developed countries like US, which has about 6%, and UK, for example, Europe, that has around 7%, you see, ours, we are not sure. So we cannot, people will pick the 20%, forgetting the 2%.
Yeah, it's between
Why are we
2
not?
and
Yes.
20.
And the 2% is still important, because you might say, oh, we are doing well because we are just 2%. We are behind the US, which is 6%. That is not true, because we've not validated those numbers. We need to know if indeed we are okay as Africans. But all of us are not talking about brain diseases. But when we think about it, we have someone in our communities, someone in our families who has exhibited some of the symptoms that I've talked about.
Is it not because we don't see a physiological manifestation that perhaps that's why we don't think that brain health or mental health should be prioritized? Because if you have malaria, you have a fever, right? You have the chills and you feel physically unwell. It's difficult for somebody who is suffering from Alzheimer's or any other dementia or any other mental health to really explain to you that I have a fever and you can test me and I'm 40 degrees, or that I have chills, or that I'm grinding my teeth. Is that perhaps one of the reasons why it could not be prioritized?
Correct. And because, as I mentioned, some of the symptoms, some of the brain abnormal changes will start happening, but they won't impact your functionality.
Yeah.
You'll still function. So people will not talk about it because you don't even know that you have this problem. How many people are able to go, when you talk about people going for medical checkups, they can go for other medical checkups, HIV, malaria, But when it comes to brain imaging, how many are going to pay money to do a PET scan to check whether, or even to do some biological tests to check whether they are at risk of that condition? So true, people might not talk about it because they don't even know, it's not affecting them directly. There's no that physical manifestation. But number two, there's a lot of stigma and discrimination around that. So as I mentioned, when you see someone wondering, your grandfather is walking around the community, then it's not the grandfather who is stigmatized alone, but also the entire family and the entire community. That family practice witchcraft, for example. So you see, people will not want to talk about it. What do? They'll end up locking this person within the compound at home. They don't release them to go out. And that is dangerous. So another thing is that talks to us the importance of early screening and early detection, so that we don't end up sending people to the hospital when they are at moderate to advanced stages of Alzheimer's. At that level,
is expensive, though, isn't it?
It is expensive. That's why I said it's important for the government to really prioritize and invest in this. We need to have tools to properly diagnose people, and even sensitize our primary healthcare facilities to start screening. Let's not just do something. Let's not just sit and do nothing because it's expensive. If you think about it, what is the cost of inaction?
Yeah,
right.
So it's a lot more to many more people than just the one person who's. Now, Wango is asking, how does one volunteer for this research? Empress is asking, Ikoka Kiru.
So they can contact us through our website, the Brain and Mind Institute, Aga Khan University. Sometimes we have positions for volunteering. We also collaborate with caregivers, those who are listening online. people who are working, who have their loved ones. We really like learning what is happening, but also collaborating with them. So if they check online, sometimes we have, even the training programs I talked about, we usually advertise them on LinkedIn, on Twitter, on our, social media spaces. They can always get in touch and see the opportunities to collaborate with us.
Okay. We thank you very much, Doc, for coming.
Thank you so much.
And as you get more information, please come back.
Thank you.
And let us know. Dr. Edna Busire is a medical anthropologist, Aga Khan University Brain and Mind Institute. She has been taking us through dementia and mind resilience and what the Brain and Mind Institute of the Aga Khan University is doing to basically get to understand our brain diseases and our mental resilience and brain resilience in Kenya. It's 8 a.m. Time for the news.